Hello, everybody. I'm going to give everyone just a second to get logged on, and then we will get started. Awesome. Thank you all for joining us for today's RDLA webinar. In honor of May being Mental Health Awareness Month, we are doing this webinar on the connection between mental health and rare diseases. We know that this is a topic that the rare disease community is invested in and interested in learning more in. So we have an amazing panel for you guys here today. Before we get started, I'm just going to go over a couple of housekeeping items really quickly. If you prefer to call in to today's webinar, you can do so using the phone number and the webinar ID on the screen. If you have a question for any of our panelists, you can type your question into the Q&A box and a member of our team will direct your question to the speaker. And just a reminder, if we have any media joining us, we ask that you reach out to panelists after the webinar for any direct quotes. And of course, closed captioning is available for all of our RDLA webinars. So if you're interested in using that, you can click the live transcript button at the bottom of your window. And of course, we also have Spanish translation services available. The link to utilize those has been posted in the chat. So if you're interested in accessing the live English to Spanish translation of the meeting, you can just click that link that is in the chat. So this is our agenda today. We are going to start out hearing from Kathleen Bogart from Oregon State University and Kathleen Miller from the FDA. Both Kathleens are here to talk to you about their research in the mental health and rare disease space. Then we are joined by Joanna Rosen from the American Foundation for Suicide Prevention. Joanna is going to speak to you all about pieces of federal mental health legislation and ways that you can get involved. Then we have Crystal O'Loughlin from Angel Aid. Crystal is joining us to talk about the work that Angel Aid does in providing resources for rare disease patients and caregivers. And then last but certainly not least, we have Corinne Cannon, who is one of our young adult rare representatives. She does work with the Mitosis Support Organization. You can correct me if I was wrong on that name, Corinne. But she does work with them in providing mental health support to the youth and their foundation. So she will be talking to you from a rare disease perspective and also her perspective in providing that support. So Kathleen, I will go ahead and turn things over to you to get started.
Great. Thank you so much for having me and for hosting this really important conversation. So I'm Kathleen Bogart. I'm an associate professor of psychology at Oregon State University. I have a rare disorder myself, have family members with rare disorders, and have been in the research and advocacy space for more than 15 years on this topic. Next slide, please. So today I'll talk about the psychological overview of mental health in the rare disease community. Next slide. So I think we all know what rare diseases are here, but I think it's really important to highlight some of the commonalities that we all have. So 1 in 10 Americans has a rare disease, so the experience of being rare is actually common. And there are only about 5% of rare diseases that have an FDA-approved treatment. Next slide. Next slide, please. Looks like one was skipped. There we go. Thank you. So I want to highlight that although there are more than 7,000 different rare diseases, there are actually many things that we have in common, especially psychosocially. So it can be helpful to look at diverse rare diseases together in terms of our experiences. And here are some of the universals we're finding. So first of all, we obviously have a need for specialized support. We know that the average diagnostic odyssey takes 7 to 9 years. years, and that 2/3 of people with a rare disease feel that they do not get enough social, informational, and psychological support through the healthcare system. Next slide, please. And another rare disease universal is stigma. And that can show up in two main categories. First of all, there's that lack of awareness that we're all aware of in this community. And that can result in others blaming people for their rare diseases, minimizing their experiences because they don't believe that they are legitimate, they haven't heard of the condition before, and people can experience more outright discrimination in the job and healthcare spaces. So I want to share a quote from some recent research that we did. So one participant said, "Because my main symptom was excessive sleepiness, people in my life told me to grow up and that everyone's tired. I cried happy tears when I got my diagnosis because it validated years of self-doubt and struggle." And then, of course, stigmatization can also manifest in isolation. We know that often we are the only people in our community with our rare disease. In another study, we found that people said they wanted to feel that I'm not the only one struggling with the obstacles I face. Next slide, please. And so I want to focus some of my time here on a health-related quality of life study that we did in partnership with the Minnesota Rare Disease Advisory Council. And with them, we were interested in focusing on a baseline in Minnesota, just as this council was forming. And our plan is to then do this survey again after a few years that the policies that this council has advocated for will come to effect. So we not only surveyed Minnesotans, but we also surveyed all of America. And that's the data that I'll show today. And in fact, we did not see a difference between Minnesotans and Americans at large. So we collected data from over 1,000 adults and caregivers living in the US. And 344 different rare diseases were represented here. We conducted an internet-based survey with validated tools, including ways to measure stigma. We used the PROMIS battery of scales to measure health-related quality of life, and we also measured patient satisfaction. Next slide, please. So we found that over a third waited 4 or more years for a diagnosis, that a half experienced 1 or more misdiagnoses, and 2/3 felt that they had insufficient psychological support. So very important to highlight today. And when compared to US population norms and the norms for people with common chronic diseases, people with rare diseases scored significantly poorer on all measured scales. So they had greater stigma and they had greater depression, anxiety, physical symptoms, and all of those issues. Next slide, please. We also found that there was lukewarm patient satisfaction. So people were more likely to be satisfied when they experienced a shorter diagnostic odyssey, when they had less stigma, less pain, and better physical functioning. And, as I mentioned, we had these high levels of anxiety and depression in both children and adults. We were able to do some analyses to see what predicted anxiety and depression, so things that we might be able to intervene on. So people were less likely to have those symptoms when they had lower stigma, lower fatigue, less sleep problems, and a more stable disease course. Okay, next slide, please. So, I presented some pretty dire findings, which also are probably not that surprising to many of the people listening here. I want to then offer up kind of some optimistic findings as one potential avenue to provide psychological support. And so many rare disease organizations offer support groups or support foundations for people with the condition and their families to get together. One example of this is the Mobius Syndrome Foundation, which is an organization I've been heavily involved with. And we did a study looking at the experiences of people attending these conferences. So we know that people with rare diseases and their families want to meet others with their condition, but most have never done so. So support conferences like these really offer a practical approach to connecting. So like many other rare disease conferences, this foundation conference is held over a long weekend and has a number of attendees from around the US and around the country. Next slide, please. So we wanted to kind of conduct a pre-post study in which we examined some psychosocial factors before and after the conference occurred, and we surveyed people who did and did not attend that conference. Again, we used standardized and validated tools to look at things like social support and stigma. And then we also left some open-ended questions so we could learn more about people's experiences. Next slide, please. So quantitatively, we found that among adults with Mobius syndrome, after attending the conference, they experienced greater social support, reduced stigma, and enhanced knowledge. And parents got different benefits, which was what we predicted. So parents got increased rare disease self-efficacy, meaning that they felt more confident to manage their child's symptoms of their condition, and they felt that they gained more knowledge. Next slide, please. And then I really love to share some of these quotes. We found lots of themes of social support. So one adult with Mobius said, "It's the rare place that I feel normal." We also found a nice theme of role models, where a parent said, "It was really encouraging to meet adults who have Mobius syndrome and to see the adults and teens knowing that our kid would be okay, that he'd grow up and be successful." And almost in response to this quote, an adult with Mobius said, "I enjoy and embrace being a silent role model for parents and kids." Next slide, please. So to conclude, based on that overview I presented, it's clear that there are unmet needs in the rare disease community, high levels of anxiety and depression, and people in the community themselves are saying that they have unmet psychological needs. One example of a potential intervention are support groups and conferences, although we need to have other options available as well. Next slide, please. So I want to highlight some policy implications here as well. In 2020, I analyzed the NIH's total budget towards rare disease research, and actually a large portion of it, according to my estimation, is focused on rare disease research, so 14%. But when I looked into the details of what these funded studies were doing, only 0.02% included psychosocial research in addition to, say, clinical trials on medical treatments. Additionally, the majority of rare disease organizations, their mission statements and their funding priorities primarily focus on medical treatments and cures and do not include psychosocial issues. Next slide, please. So, this all points to the fact that the traditional rare disease model funds medical research and treatments and is focused on each individual disease, right? And this is understandably very slow going, given that we have more than 7,000 of them. This is one reason why we only have 5% of our diseases with FDA-approved treatments. I really want to advocate for the need to fund psychosocial research and treatment at a similar level. This is more immediate cost-effective, and efficient than treating individual rare diseases as our only focus. And the benefit of psychosocial research is that we can actually benefit many people, many different types of rare diseases all at the same time because of these shared commonalities that I've mentioned. Next slide, please. So thank you very much for your attention. And if you're a QR code person, you can connect with me by following that link. And you can also email me at kathleen.bogart@oregonstate.edu. Thank you very much.
Thank you so much, Kathleen. I'm not seeing any questions in the Q&A now, but we'll do a round of questions at the end of the webinar. So stay tuned for that. Awesome. I'm going to now turn things over to Kathleen Miller. Kathleen Miller is joining us from the FDA.
Great. Thank you so much, Caitlin. And I just want to start off by thanking EveryLife and RDLA for inviting me today. Next slide, please. So I've been asked to talk today about clinical trial considerations for rare disease and mental health. And I'll just start off by saying a little bit about my background. I'm a senior economist at the FDA in the Office of Orphan Products Development. And if you're not familiar with our office, we administer a lot of the economic incentives of the Orphan Drug Act. So we administer orphan drug designations, as well as the clinical trial grants and natural history grants for rare diseases at FDA. Next slide, please. So just a brief disclaimer that the views I express in this presentation are my own and are not necessarily those of the FDA. Next slide, please. So the mental health burden of rare disease is both substantial and well documented. There's a lot of dimensions that contribute to this burden, including symptoms, often varied or multi-systemic symptoms, uncertainty around the disease with disease progression, or even just what symptoms are going to be flaring day to day. There's financial uncertainty that contributes to the burden. So the cost of medical treatments, the loss of work or work time, school, and also social, as Kathleen so nicely highlighted in the last presentation, with isolation, loss of friendships, all contributing to this mental health burden. Next slide, please. So recently at FDA, we conducted a research study looking at commonalities across rare disease patients. And one of the commonalities, and we used patient engagement sessions where patients come and speak to the FDA either through patient-focused drug development meetings or patient listening sessions. These are all also publicly available on the website, and the quotes that I used throughout this presentation are pulled directly from those summaries. But one of the main commonalities that we found that I don't think anyone on this call is going to be surprised by is the significant mental health burden that patients face. One patient shared with us through all of this, their rare disease symptoms. The other most debilitating symptom is mental health. I suffer with depression. I suffer with anxiety. And depression and anxiety were themes that came up frequently in these sessions. Another patient shared, there's a big mental health component to rare disease that needs to be acknowledged. I desperately would have needed access to mental health resources, but no one thought about providing those to me. So they're really not part of care plans for patients. And that's a major issue because this is a substantial symptom for patients and a cause of from those. Next slide, please. So to move into the clinical trial considerations, and I'll note here that I have just a very short time to talk, so I'm not going to be speaking to everything that's possible, but trying to give a brief overview for everybody to kind of keep in mind when they're thinking about trials. And just to note that any kind of protocol changes should only be made in consultation with oversight bodies such as IRB, FDA. I think when we think about how to benefit mental health in clinical trials, we think about something that I would term direct support, which is provision of mental health resources within the context of the clinical trial. So thinking about counseling or therapy, and also thinking about support groups. Next slide, please. However, as we all know, direct support is not always going to be feasible in these contexts. There's a significant financial component, and there's also an issue of finding providers finding mental health care providers for counseling or therapy, and any sort of facilitator for those support groups can be difficult to find. So what I want to focus on more today is what I'm going to term indirect support, which is trying different ways of minimizing the burden on participants in enrolling in these trials and continuing in them, and making sure that trialists have an awareness of the different ways that the trials are burdensome to participants and can contribute to their overall mental health burden. Next slide, please. The first piece I want to discuss is travel. So we've had participants, for example, this first quote here, share with us, he had to travel from Dallas to Boston 12 times in 2 years to participate in a clinical trial, which was difficult physically and logistically. And another patient group shared with us, distance from where the patient caregiver lives to the trial treatment center also determines how burdensome the visits are. So one thing to consider is creating multi-center trials where the sites are dispersed throughout the United States. This ensures that patients are at least closer to the treatment site. And while we all know that, creating multi-center trials is sometimes more expensive, costly than a single site trial, there could also be trial efficiencies that are picked up with multi-site trials. For example, greater enrollment, more patient retention, because it is less of a burden on patients to participate. Next slide, please. And then secondly, visits. Patients have shared with us the frequency of visits to the treatment center is burdensome in the beginning of the clinical trial, but becomes less burdensome over time when the frequency decreases. So trialists should definitely consider the number of visits and possibly consolidating visits where possible. Obviously, this might not always be possible. If you need a 6-month check-in and you need a 12-month check-in for the endpoints, then you're going to have two visits. You're not going to be able to consolidate those, but there are definitely cases where consolidation or at least consideration of other methods of these visits is reasonable. For example, community collection of samples or scans where possible, or utilizing virtual visits for interactions that don't need to be in person or don't have a physical component to them. Next slide, please. And the last type of indirect support that I want to talk about is types of testing. So we had one patient share with us, I don't know that people putting together these trials understand what a pain that is to do 24-hour urine tests if you're working or in and out of the house throughout the day. So there are definitely considerations where if you have an extended type of test that you have to perform as part of the clinical trial, if you're not planning to be home all day, that's going to affect your work, your school, your ability to socialize, and all of those are contributing even more to your mental health burden. So I think for trialists, just keeping an awareness of the burden that these types of testing or infusions, things like this that may take up a lot of patients' time, the burden that they cause, and to try and seek alternatives to those where possible. Obviously, they're not always going to be possible, but hopefully there are instances where we can alleviate the burden on patients. Next slide, please. So to summarize, participating in trials definitely can cause additional mental health burden for rare disease patients across these different dimensions: travel, time, stress involved in the uncertainty. Direct support, like support groups, is likely going to be very beneficial where possible. And I think Dr. Bogart's research shows that as well. That was a really nice tie-in. And trialists should consider indirect support, for example, to try and minimize the burden of participating, to help alleviate some of these mental health burdens that come with enrolling in trials, and potentially this may also lead to greater trial efficiencies as well. So an added benefit of incorporating these types of indirect supports in clinical trials. So from there, I'll wrap up, but I see there might be a couple questions, so I'm happy to answer.
Awesome. Thank you so much, Kathleen. Yes, we do have a couple questions for you. The first one is for support groups. Are participants in the same trial able to participate in support groups, or are there conflicts with participants talking with each other about their experience?
Yeah, that's a great question. I think I would have to investigate that a little bit further. There's obviously confidentiality issues. Patients may have to opt into that. I wouldn't want to speak for all trials, but I think there's likely ways that that could be done. But the person asking the question is right, that I think that there are some question marks there that would have to be thoroughly looked through.
Got it. And last question for you. What do you think is the biggest barrier for men with mental health challenges and rare diseases? And how should we include them as well?
I mean, I think based on our recent research, looking through the commonalities, and I'll just also say a big thank you to Catherine Meese, who was our fellow who took the lead on that project. I think the feelings of isolation, and I think that came up in Dr. Bogart's research as well. I think that's a huge contributor. I also think that feelings of dependency with family and just the feelings of kind of differences and being different was a theme that we saw across a lot of rare diseases. And then lastly, the feelings of uncertainty around the disease, how it's going to progress, how people are going to feel day to day was a major contributor of their stress for their rare disease. In terms of how to put that into trials, I hope that having some hope also would contribute to alleviating some of that burden. Although, as we know, hope without action is, not what people want. So, yeah, I think it's a good question, but I hope that the support groups, things like that, making the trials less burdensome to participate in, can all alleviate some of that.
Thank you so much. And I have one more question, and Kathleen Bogart, this may be a question for you to answer as well, either of the Kathleens. How do you guys suggest finding mental health professionals who are knowledgeable about rare disease challenges? One of the attendees is asking for themselves and said that providers could either be online or in person.
I might let Dr. Bogart take the lead on that question.
Well, I get this question a lot, and so I will give the general answer, which is, unfortunately, there is not kind of a clearinghouse where these things are listed, although this is really something that I would love for rare disease organizations and advocates to put together. In the meantime, often the best way to do this is to look on the various mental health and psychology services, like the APA's list of available, APA stands for American Psychological Association, their list of psychologists by specialty. And we would click chronic health, because rare disease is not an option. So people with general experience with chronic health will have some idea of the challenges, although I've highlighted that the challenges of having a rare disorder are uniquely magnified. I'll also say that I have a few people who I can recommend. So if anyone would like to email me, I can send some personal recommendations.
And
Thank you. Oh, yeah, go ahead.
I'll just add very quickly onto that one of the points of our research that we found is that, like Dr. Bogart said, there aren't resources on, for example, patient websites, patient advocate websites. So I would definitely encourage any patient advocates on the call to try and help provide those resources for their community.
Great. And Kathleen Bogart, if you don't mind to put your email in the chat for anyone who's interested in reaching out, that would be super helpful. Awesome. Joanna, I'm going to go ahead and turn things over to you. Joanna is joining us from the American Foundation for Suicide Prevention, and we'll be talking to you all a bit about federal mental health legislation and ways that you can get involved. Thank you so much, Caitlin, and thank you to Every Life and RDLA for inviting us and including AFSP in this important webinar, and also to all of the previous and upcoming panelists for sharing your time and expertise. This is such an important discussion and really grateful to be here today. I'm going to talk a bit about our suicide prevention policies, sort of come at this from a suicide prevention lens, and some broad mental health policies, as well as the different risk factors that we really need to consider when we are talking about suicide. So if you can go to the next slide now, please. Thank you so much. So as a little background, AFSP was founded in the 80s by a group of families who had lost loved ones to suicide. We have grown to establish chapters in all 50 states with volunteers in all 50 states, DC and Puerto Rico at this time. Our mission is really to save lives and bring hope to those affected by suicide. We are an advocacy organization, so we focus on furthering these goals through our core strategies, which you see up on the screen here, funding scientific research into suicide trends, suicide prevention models that really work, as well as promoting public education and awareness in terms of mental health and suicide prevention, sort of fighting that stigma that I know was mentioned earlier before. We also, advocate for policies at the state and local and federal levels, which is where I come in and what I mostly focus on. And we also try to provide supports for suicide loss survivors, as well as those who have lived experience themselves. And you can go to the next slide. So we have 4 policy priority pillars, which I won't dive into too deeply right now. I will share the links later on that you'll be able to read those in more detail. But these really include, research and data collection, building out our infrastructure at state levels to collect information and inform our suicide prevention policies. We also focus on access to care and mental health and suicide prevention services, making sure that, the people who really need the support are connected quickly to the care that they need when they need it. We also know that certain populations, as we discussed today, and communities can be disproportionately impacted by suicide. I'm also going to talk a little bit about that later as well. But one of our pillars is really focusing on concentrating our efforts onto these populations that are at disproportionate risk and making sure that we are meeting them where they are and figuring out strategies that really work to lower the suicide rates in those communities. And finally, our bold goal of reducing suicide by 20% by 2025 focuses on activating these 4 critical areas of impact, which research has shown us will have the most impact on reducing the suicide rates. And those include firearms, healthcare systems, emergency departments, as well as correction facilities and systems. Next slide, please. So suicide is a very complicated issue. It's multifaceted, has lots of impacts. So it's really a public health issue. And when it comes down to it, we need a public health approach to lower the rates and stop suicide. It results from not one single cause, but a convergence of many factors. This can be internal, so genetics, predisposition to certain mental health conditions, or external factors as well. So environmental changes or situations that have actually been discussed, like friendships falling apart, stuff like that. So certain factors or combinations of these factors can lead a person to be at increased risk for suicide. In 2021, which is the last year that we have data for at this point, the suicide rate unfortunately increased across the country by 4.79%, almost a full 5% increase after we had seen 2 back-to-back consecutive years of decreases in the suicide rates from 2018 to 2020. So about 48,000 individuals died by suicide in 2021. So that's what we're working with right now. We're really trying to lower that rate. We're trying to look at which populations are dying by suicide, how we can prevent that, and how we can really support the people who are most impacted. We do know at the end of the day that suicide is preventable, and looking at these trends and figuring out who's at increased risk for suicide, which populations we really need to be focusing on, can help guide our prevention efforts as we move forward. So you can go to the next slide. Thank you. So like I said, many factors can contribute to suicide. Many factors contribute to physical and mental health. The link between chronic and ongoing conditions, as well as rare diseases and mental health and suicidality, is still being explored. But research indicates that chronic pain conditions can lead people to be at a higher risk. AFSP actually funds research on this topic right now, so we're hoping to have more information, more definitive information on these links in the coming years, and we'd like to sort of shape that into policy solutions. So next slide, please. Like I said, many populations are at increased risk for suicide. There are many racial and ethnic minorities that see higher rates when compared with other racial and ethnic groups, as well as different age groups. In particular, I want to focus on youth as well as older adults. Youth in particular see a much higher risk for suicide. Unfortunately, suicide is the third leading cause of death for children ages 10 to, or youth and young adults ages 10 to 24. The Surgeon General actually recently issued an advisory acknowledging that there's a youth mental health crisis ongoing, as well as offering solutions to address it. And again, older adults also, we often see struggle with ongoing or struggle with higher rates of suicide. We also see older adults dealing with ongoing and chronic conditions as well, and that can cause increased risk for suicide. So, just these statistics show, adults ages 75 and older have one of the highest suicide rates of most age groups. So that's 20.3 per 100,000. And particularly men ages 75 and up have the highest rate when compared with other age groups, and that is 42.2 per 100,000. So it's pretty drastic, definitely, and these are groups that we can really focus on to try to have a deep impact. And you can go to the next slide now. So what can we do to stop suicide and lower rates across all populations, but specifically focusing on the ones that are at increased risk? What AFSP does, what we all try to advocate for, is passing legislation. So that's what I'm going to talk about, some of the federal policy solutions that we have to support specific communities and populations, giving them better access to care, more effective training, prevention programs, as well as helping to reduce the stigma of asking for help, because we know that bringing this to light, talking about it, can really go a long way to making people feel more comfortable and supported when they need to reach out for help. So one of the bills that I'm going to talk about this year was actually introduced last session in the 117th Congress. AFSP is currently working with Representatives Napolitano and Fitzpatrick and their offices. This bill is forthcoming. It's going to hopefully be introduced again next week. That's our tentative intro date. We've been working with their office for a few months now, getting the finishing touches on this bill. As it was introduced last year, and it didn't pass, so they are reintroducing it this year. But this is bipartisan legislation. It will help schools address mental health challenges facing students by providing funding to strengthen school-based mental health services, which could include screening, treatments, outreach programs. It also provides funding for schools to build partnerships with healthcare providers, as well as child welfare agencies and any other community-based services in their areas. And it also supports training for teachers to help them identify signs and symptoms of mental health conditions, risk of suicide, or maybe trauma exposure for their students in their classes. The bill also supports development of best practices for delivering mental health care in school-based settings, because we know that reaching students where they are in their schools can really help connect kids to care when they really need it. So this bill, again, will be introduced hopefully next week. We are in talks with the offices who are introducing it, and we'd really love to have people support it. If you want to get involved, I will have some information later on about how you can reach out to your members of Congress and ask them to support this bill once it is introduced. But you can go to the next slide now, and I'll talk about a different bill that we also support. This one was reintroduced this year, this week, actually, a couple of days ago. We're very excited about it. It would ensure access to mental health care, but it would help specifically older adults for the most part,
And this is also bipartisan legislation coming from Representative Matsui and Johnson. And this bill would expand access to care and make sure that people who might not be able to access care in person can receive it through telehealth. And this is important because a lot of people who are at increased risk for suicide or mental health conditions, like older adults, also those with chronic conditions who maybe can't make it into an in-person appointment, or rural populations where healthcare providers are really, really far away, and it takes, you would have to take a full day off of work just to go to the doctor's office. This bill would really help make sure that these patients can receive care and coverage through Medicare without having to make those time-consuming and often very taxing trips in person just to keep them getting the care that they need. So this is another bill that we're really excited about, the Mental Health Care Access Act. So again, it was just introduced. We're looking forward to that. And we think it can go a long way in terms of bridging that barrier of just access to care by making telehealth more accessible. And we can go to the next slide now. Another area we focus on for connecting people to supports is not a bill itself, but it's 988, the Suicide and Crisis Lifeline. This is the new 3-digit code for the Suicide and Crisis Lifeline, which was formerly a 10-digit longer phone number, and it connected to the National Suicide Prevention Lifeline. This came online as 988 in July of 2022, so we're almost at a full year of operation. After really years of groups advocating and mobilizing support to have a 3-digit suicide and crisis prevention hotline that would be accessible nationally and 24/7 wherever you are, So the Substance Abuse and Mental Health Services Administration, or SAMHSA, is the government agency that receives the funding for 988. And SAMHSA issues guidance for crisis services, focusing on 3 core elements, which you see as someone to call, someone to respond, and somewhere to go. When you think of a hotline, you probably think of the call centers where, if somebody's in crisis, they call up the call center, get support over the phone, and they're able to, stabilize their situation, figure out what supports they need, and then go, on with their life. That is often a lot of what happens when somebody calls the lifeline, but it's not it needs to be built out beyond just the call centers. So these 3 core elements of a crisis care continuum, someone to call, someone to respond, and somewhere to go, make up the lifeline and make up the broad crisis care continuum in our country. So that could include, the call centers, there's someone to call, obviously, but then someone to respond, or mobile crisis units or teams of people who can respond to you and come to you in person if that's what you need, to provide, hands-on support when someone is in a crisis, as well as somewhere to go, which is, a crisis stabilization facility, a respite center where somebody can have a comfortable and safe place to recoup after or during a crisis. So it's really critical that these areas be sustained, supported, funded, so that everyone experiencing any crisis across, the broad spectrum, whether or not that's suicide, it could be a mental health crisis or a substance use crisis. We really need to make sure that this continuum is built out so that anyone in need can reach out and get the help and the immediate support that they need. So this is one of the areas that AFSP really pushes to support. We advocate every year for funding in the federal budget. This year is no different. We really need to make sure that 988 is easy to access and provides helpful support to people in crisis. Again, whether that's a mental health, substance use, or suicide crisis, really connecting anyone in need any time of day, regardless of geographically where they are, with 988 supports is going to go a really long way in preventing suicide, but also helping people get their mental health needs addressed. And we can go to the next slide. So thank you so much for your time today. Mental Health Awareness Month is the perfect time to get involved and advocate for suicide prevention policies and mental health care expansion. AFSP volunteer advocates can take action by reaching out to your lawmakers and encouraging them to support the legislation that I've mentioned today, and encourage progress on policy areas. And we use action alerts to really drive this outreach to lawmakers. You can sign up to be an advocate and take part in these action alerts through these links here. I'm also happy to share the links with Caitlin or drop them in the chat, whatever is easiest. And I'm happy to take any questions anyone has either now or during the Q&A. Happy to do whatever.
Amazing. Thank you so much, Joanna. We do have a couple questions for you. Someone is asking, how can patient advocacy groups do better incorporating mental health?
Patient advocacy group efforts. That's a really good question. I think a lot of the time stigma plays a real role in just bringing these discussions top of mind. I think that making sure that patients feel comfortable talking about these things. I think advocating for these policies that would make access to care more accessible and more readily available would go a long way in terms of making patients feel supported.
Great, thank you. And the second question for you is, do you all have resources for people who may have experienced suicide from a loved one?
Yeah, so AFSP does have programs and support programs. We aren't a provider, so we aren't like therapists. We don't have our own support. We aren't a medical provider, but we do have a lot of programs and supports. We have some communities that people can join to find support and companionship. So I can definitely drop all the links that I shared, as well as the page to our programs department there as well in the chat.
Yes, that would be amazing. And I do have one more question for you. I'm sorry.
Perfect.
So
no, that's fine.
How do you reconcile mandatory reporting or in-person interventions or immediate phone support for mental health crises with crisis centers not always having an education around rare disease and their unique support needs? And what can be done to better support rare disease patients in these emergency situations?
That's a really, really good question. Mandatory reporting and crisis response is definitely something that, as 988 has come online, a lot of groups are learning about and trying to figure out what the best ways to handle that need to make sure that people are kept physically safe, but then also making sure that we're respecting privacy. Balancing that is so important. We need to make sure that people reaching out feel supported and comfortable and safe sharing what they are going through. I think right now what we need to be doing is really diving into these issues and talking about them and trying to figure out what works, what doesn't. I think in terms of rare diseases, I think, I know personally my experience is in suicide prevention policy across different populations, but I know for sure that I have less expertise in the rare disease area. So I would ask, I want to be educated on that. So I would want to, connect with you all and hear from you about what your policy recommendations are. Maybe not necessarily policies, but, what have you found that works? What have you found that would make people feel comfortable? And then we can, dive into that and take that apart and figure out how we can put those into action through policy. So I hope that's a good answer. I think it's an ongoing discussion, and just with 988 being so new, I think we are, very much learning still how we're going to respect different populations' needs, because every group has different sets of needs. And that's actually something that we're trying to figure out with youth specifically is, the crisis care continuum was built out with adults in mind, but children are not mini adults. So how do they react? How do they respond? What do they need? So long answer. I hope that was helpful. But basically just, I would love to learn more myself. So any information is great to be shared, and I appreciate the opportunity.
Thank you so much, Joanna. And that question leads really beautifully into our next speaker. We are joined by Crystal O'Loughlin from Angel Aid. Crystal is going to talk to you guys a bit about the resources that Angel Aid provides to rare disease patients and caregivers. So Crystal, I will turn things over to you.
Fantastic. Thank you so much. I'm so excited about this conversation, and it's a beautiful coupling of research, the clinical trials perspective, the extreme sort of crisis support and suicide prevention services. And what we're here to talk to you about is the actual support groups that we're hosting, as well as the mental health education for patients, caregivers, and professionals. So this is an ecosystem that needs emotional support, and Angel Aid is here to provide that support directly, but we also represent a coalition of stakeholders who are helping to bring tools into the community. And I'm talking the broad rare disease community from a disease agnostic standpoint, to actually bring tools that can be used to educate individuals, but also educate social workers, genetics counselors, psychologists, psychiatrists that are working with our rare families. So I heard a lot of questions about that, and we're going to talk a little bit about that today. Next slide, please. And if you go to the next slide, really, I just wanted to frame out that, again, the emotional well-being, the mental health needs are multifaceted. There's needs within the patient community, especially as children are aging into young adult and adulthood. There are mental health and emotional well-being needs within patients who have caregivers, as well as parents and siblings and extended family members that are also being emotionally impacted by this rare disease experience, as well as the kind of concentric circles of professionals that are supporting rare families. So teachers, the fire department, patient advocacy organizations, the researchers, the scientists, right, are also being impacted emotionally. It's hard in universities and in research environments to actually recruit some students into this field, because this concept of hope is so acute, and the reality that we're living in is we don't have cures and we don't have enough treatments for rare disease. So that's what I call empathy math. 350 million families multiplied by 0 cures means we've got a global mental health crisis on our hands. So next slide. And I love that, Kathleen, you are on this panel today, because we cite your Psychology Today article so much. It's really important when we're talking about support for families, patients, as well as their ecosystem of support, that we differentiate between informational and tangible support, which is, education about the disease, how to get insurance claims covered, how to do treatment and symptom care, versus the feelings that individual is having about that experience. So think of the triage list of things that have to get done. And then at the bottom of the list is, how am I actually feeling about this experience? And what we know is that emotional support and companionship has the most impact on a metric of well-being in that individual patient, as well as their concentric circles of support. So what we're talking about is personal connection and emotional support services. Next slide. Next slide, please. And next slide. There might be a delay. Hello?
Can you see the slides, Crystal?
Okay, we can now. Yes, thank you.
Perfect.
I'm not sure how far ahead we skipped, but this is fine. One of the things that we do at Angel Aid is weekly support groups. So our weekly support groups, putting a mental health education track once a year on a conference is a good, it's a good start. It's a good awareness building session, but to actually bring emotional relief, we do need to have regular interactions. So Angel Aid supports weekly support groups specifically for rare mothers, rare fathers, young adults. We have a Spanish speaking support group launching, and then we do have some country specific groups. What we don't do is support groups by disease. And the reason we don't do support groups by disease is because the conversation tends towards disease management. And if we're going to bring mental health and wellness relief, we want the conversation to focus on feelings. So these are practitioner-led conversations that are peer-to-peer support groups. The difference between a one-to-one relationship in therapy versus a peer-led relationship in a group setting is that when someone shares their feelings, the facilitator would then ask, how does the group feel about what was just said? Who can reflect back to that person what was just shared? Okay, so that's going to be a much more scalable model for us to be able to provide support versus one-to-one patient or caregiver to a therapist. There just simply aren't enough therapists out there. And we also need to educate the therapists on the unique considerations within rare disease. So weekly support groups are important. Next slide. We also provide caregiver and patient and professional education. We do that in webinar formats as well as 6-week virtual retreat formats, which are 1 to 2 hours a week. And then in some cases in person, so maybe 4 days and 3 nights, and I'll show you some examples of that. The education materials are all available publicly, and they're also being translated into multiple languages. So our Sustainable Mom methodology was expanded recently to the Sustainable Caregiver and has been translated into 8 different languages for use by patient advocacy organizations, or we can lead the groups. So often what we'll do is do some co-funding requests and then partner with various different organizations. We also want to make sure that the community experiences the relief and some of the ancient arts of sustainable relief, like meditation, yoga, using your senses, sight, sound, taste, touch, and smell to ground you into the present. One of the things we all learned from COVID is that we can get isolated, we can get stressed, and that there's a lot of things that we can actually do for self-help and self-care. And so that's what Angel Aid is constantly pushing out, is the inspiration and the training and the encouragement to do those daily mini doses of self-care. Next slide. What we also know is there are acute mental health moments within the family. We know through our research with Indiana University School of Social Work, for instance, that needle pokes, again, this is not disease specific, this is disease agnostic, but needle pokes are a big part of a medicalized life. And about 10 to 15% of individuals, patients are dealing with needle fear and needle phobia because they're constantly getting poked and prodded, either through the receiving of drugs and medications, or testing, constant blood draws in order to test and see what different markers and levels and efficacy of different interventions are. And so we've developed a holistic healthcare approach to dealing with needle pokes and needle fear. It's called traumaless needle pokes. We actually run a webinar and then ship a wellness kit into the family that has discussion guides as well as worksheets. Really, needle fear is about control, getting control back into your life. And so we have control of that experience can be managed through various different things like hydration the day of or the day before, or using some non-invasive techniques like distraction, or the buzzy, which is a vibrating bumblebee. We also know that when we're working with teens and young adults, that accessing emotions and feelings is best sort of done in alternative formats. For instance, we use a graphic novel format. Let's do some storytelling. Let's actually do some illustrations and talk about feelings through the development of your own specific graphic novel. So, so these sort of backdoors to therapy in a small group format, in a consistent weekly support format, is how we not only address emotional well-being, but we actually sustain it, which is what we're trying to do here. Next slide. And I'll go kind of quickly through these. Everything that we have been doing is meant to be scalable and made multilingual. So I'm really excited to say we've spent about the last 7 years focused on establishing methodologies that can be used in any rare, chronic, or complex disease community, and then testing those experiences within various different communities, and then actually starting to translate and make available in other languages. So we just hosted our first Spanish-speaking retreat out of Mexico City. And that is now, once you go through the in-person retreat training or the 6-week virtual training, then you're also part of an ongoing weekly support group. Next slide. In Australia, we took our sustainable caregiver methodology and actually ran it through ethics review with Sydney General Hospital and University of New South Wales. We received our IRB approval and rolled out a 6-week virtual program with the Epilepsy Foundation of Australia. So we run cohorts of caregivers through our emotional well-being exercises, and then we roll those caregivers into ongoing support groups. They end up often being the ambassadors and bringing those that training back into their communities. Next slide. And there was a question earlier about men. So women are the primary caregiver in 82% of rare families. So we have had quite an emphasis on women, but never an exclusion of men. And in fact, we've been hosting men support groups throughout 2023 and starting to expand the frequency on those. And then we're going to be hosting our very first men's retreat here in just a couple of weeks. There is a waiting list, but there's a couple more spots, but then there will be a waiting list for future retreats. So feel free to share this out into your communities, and we'll provide a link. You can just access our website and go to our events page. Next slide. And the next slide. And coming up in 2023, as I mentioned, so it's the regular interactions that bring emotional relief. So the range of crisis to wellness, we can address about 80% of the need through peer-to-peer support groups and training if we have the right tools. The crisis support, we need to be in partnership, and I see a new partner on this call. But in the crisis side, you do need one-to-one support. So we're partnered with Mental Health America, we're partnered with NAMI, we're partnered with Give an Hour, and other organizations are coming on board every month, because what we've developed, and if you go to the next slide, what we've developed is a training tool. It's based off of our concept, the Rare Givers Emotional Journey Map. And if you go to the next slide, I'll show it to you. Please notice in the upper right-hand corner, raregivers.global. That's the hub for these training tools to be downloaded and used in your community. And they are free and they're openly available. There's this discussion guide. There's this single page overview, and then there's a 32-page discussion guide to go in deeper. But really what we're showing you here is an opportunity to witness every individual involved in rare disease across every disease, and witness the potential journey that those individuals may go on. So that first moment of noticing change in a loved one and all of the feelings associated with that, adjusting with or without the diagnosis, and all of the feelings associated with that. In the third and fourth stages, we're talking about the shifting responsibilities within the family and the realities of full-time care within the family. But what isn't often discussed, even though it's ever present on so many minds, is the end of life experience. And it's so important that we acknowledge that those worries and those realities are existing in our community. And beyond the end of life experience, for many family members and others, is this concept of survivorship and finding meaning in this experience. So the 6 stages of the Rare Givers Emotional Journey Map, again, are designed to be a witnessing tool. And in the witnessing comes the relief. You'll also notice a set of relief tools along the side. Self-care, skills building is the education and training that we do, but also the emotional support groups, feeling socially connected, and then all the things that we know that we should all be doing for ourselves: physical activity, mindfulness, nutrition, and sleep. So this is a coalition of scientists, researchers, practitioners. Pretty much every stakeholder in rare disease is weighed in from a perspective on this tool, and we offer it to the community free of charge. Next slide. Okay, and I just want to mention it is May, so we do have a Mental Health Matters giveaway. If you go to the next, you can skip ahead to the next 2 slides. If you go to the Angel Aid website, what we're trying to do is encourage people to step into their mental health in some way. So either through social media or through joining the community or actively supporting the work that we do. This is our broad awareness campaign for Mental Health Matters. We're tapping into a broader dialogue. I don't know if you watched the NBA playoffs recently, but Mental Health Matters is a general hashtag, and then we're tying in our rare disease considerations to that. So next slide, please. I have my alarm going off saying I'm done. So this is good timing. But here's some ways for us to connect and continue learning. We are very excited to have the opportunity to share these with you today. And thank you very much. If there's any questions, I can take them now.
Thank you so much for sharing all of these resources. Excuse me, with our attendees. I know they really appreciate it. One question is, do you have any tools or resources for a patient when their caregiver passes away from an illness or unexpectedly passes away?
Oh, that is a scenario that we've not spent a lot of time talking about, and I'm so glad that you're bringing that up. We don't have a specific tool other than a witnessing tool, but what I will say is that talking about the feelings associated with that experience is so important. And so stepping into one of the support groups that we have would be a really good place to be able to share some of those feelings.
Amazing. Thank you so much, Crystal. I know we all really appreciate being here and learned a lot from your presentation. So thank you.
Thank you.
Amazing. So like I said, last but not least, I'm going to turn things over to Corinne Cannon, who is one of our young adult rare representatives and is going to talk to you all a bit about a patient perspective on mental health and rare diseases.
Thank you, Caitlin. Yeah, and thank you for everyone for sticking around. So May is actually Mental Health Awareness Month, but it's also personally important to me because it's also Myositis Awareness Month. And next slide, please. This is what chronic pain looks like. You won't be able to tell from the smile on my face, but every day I combat with chronic pain. And so today I'm going to give you, or I want to share my perspective on chronic pain, isolation, and community and how it affects me. Next slide, please. Chronic pain. I live with a diagnosis called clinical amyopathic dermatomyositis. Approximately 100,000 individuals have this in the United States. And I have a positive antibody for MDA5, which is related to lung disease. I luckily don't have that aspect, and I'm blessed with that. I was diagnosed in January of 2022 when I was 28 years old. I'm going to be turning 30 next month. So I'm different from the 70% of those who typically have this disease in childhood or other rare diseases that are part of that 70% of having hereditary. I'm part of that 30% that it's not hereditary. My chronic pain ranges from just pain to arthritis to the pain of my skin rashes, like having heat rash, from fatigue to cognitive impairment. But one thing I will emphasize is chronic pain isn't always physical. It can be emotional or mental symptoms. Like I suffer from anxiety. I had anxiety before I had this diagnosis, depression, loneliness, grief, and stress. Next slide, please. Part of being a rare disease patient is you often have to deal with isolation. And every day you have to do this, I call it the risk assessment, and you basically become an unintentional health inspector of like where you're going that day. If you are able to go to like the grocery store, are you going to wear a mask? If you're having visitors, are they going to be required to wear masks? And how much energy and resources all of these things are going to take, which all of these things collaborate together and make you decide, well, is it even worth going out today? Is it even worth seeing people today? One of the biggest epidemics of that's hitting in the United States is loneliness and isolation. And this was shared with the general surgeon this month for May, or for Mental Health Awareness Month. And he said being socially disconnected is equivalent to smoking up to 15 cigarettes a day for someone's overall health. And that was just huge for me. And another like statistic that really impacted me about isolation and loneliness was more than 50% of people adults reported being lonely. And being a patient with a rare disease, you often feel lonely. Next slide, please. So how can you find community? What does community support look like? It can be friends and families, and it can be neighbors to hobby groups to religious groups, coworkers, volunteers, friendly acquaintances, national and international groups. I will say with friends and families, we often think those are going to be our most immediate and most amazing support. But sometimes I have noticed that being a patient or a person with a rare disease is the people closest to us often feel the most threatened by this diagnosis, and sometimes they see it as a tragedy. And so they don't know how to respond. They don't know how to support us. And so we have to start figuring out how to have boundaries, even around our relationships, and go from there. Our neighbors can offer a lot of support. I'm the baker for the whole neighborhood, to the point where all the neighborhood kids know my name. And when I say like friendly acquaintances in the third bullet point, that can be from someone checking us in for our medical appointment to the person that drops off our medication at our home if we're more homebound. And the national and international organizations, I belong to this amazing organization called Myositis Support and Understanding, where I help with the young adults. But community looks different for everyone. It depends on how you are physically able to get out or mentally able to get out. And sometimes and also what your resources are economically. And next slide, please. Humans are hardwired for social connection. This is one of my groups that I did pop up just to talk about my day, talk about my pain that I was going through, talk about different things. And we were able to kind of update each other about different things. And so I encourage people to find community and all of these different layers, and to know that it actually helps your pain and it helps your isolation significantly. And being active within a community can help you become more connected to each other, but also helps people understand each other. I had a direct question that says, have you heard of the spoon theory? Yes. I don't use it often on my family because they're like, well, we're tired from this and this and this. And so they don't always listen, and my friends don't fully understand. But yes, the spoon theory is very relevant when it comes to energy and isolation and connecting with other people, because sometimes you have a set amount of spoons for that day or a set amount of energy that day, and sometimes getting out of isolation, whether that's online or in person, is exhausting. And on top of all the symptoms you're having to suffer, or well, deal with and suffer from. Next slide, please. So this is my contact information. You can get a hold of me at corrine.kanan@understandingmyositis or understandingmyositis.org. I know this is a very short version, but I know a lot of us need to get back to what we're doing. But yeah, that's just my perspective. And if anyone else has any more questions, that would be great. If not, totally fine. And we can go on our merry way.
Thank you so much for joining us to share your perspective as a patient advocate and also as someone who supports other people through their mental health and rare disease struggles. One question for you in the Q&A is, as an advocate, do you feel that there are different expectations for you specifically versus patients who maybe do not advocate?
Yeah, the reason I advocate is a lot of people don't have the physical ability to. And so sometimes there is that pressure of energy. Like, I'll be completely honest, one of that pictures was me at the Rare Disease Legislation Week. And I had actually one of the hardest physical pain weeks ever. And then I also flared 2 months after all that traveling. So it does put a lot of pressure because I am more physically able than a lot of other patient advocates. And it's sometimes very difficult to get out and do all of these things. Yeah.
Amazing. Thank you so much for coming and sharing and answering the questions. To all of our panelists, thank you all so much for taking the time. We really appreciate you. And to everyone attending, thank you for hanging in here with us. I know we've gone over a bit. I'm going to run through just a couple things and then we'll be done. I just want to touch on a few opportunities for engagement here. RDLA is hosting our first ever virtual Youth and Teen Advocacy Day. So this event is for those in the rare disease community between 10 and 18 years old. We are going to train these amazing young adults on how to advocate for themselves. And then they will have the opportunity to meet with their members of Congress and put everything that they have learned into action. So be sure to register for this event by May 31st. And if caregivers of young adults who are participating would like to participate and just support their loved one, you are more than welcome to do so. And then, of course, Rare Across America is coming up soon. Rare Across America is the opportunity to meet with your member of Congress at their in-district offices. So each member of Congress has an office in DC, as well as an office or multiple offices in their respective districts and states. So Rare Across America is an opportunity to meet with your members of Congress without having to come all the way to DC. So the House meetings will be in person at your member's in-district office, and then the Senate meetings will be virtual. The meetings will take place between August 7th and 18th. And you have the opportunity and the choice to participate in both the in-person House meetings or just the virtual Senate meetings. Whatever you choose to do, it is up to you. Registration for this event will close on July 11th, so be sure to register by that deadline. And if you have any questions about Rare across America, feel free to reach out to me. Our next RDLA webinar is going to be on June 22nd at noon, so be sure to save the date for that webinar. And then, of course, last but not least, be sure to sign up for our newsletter, action alerts, and event invitations at rareadvocates.org. We also encourage you to follow us on the social media platforms that you participate on, just to stay up to date with everything that's going on. And then, of course, if you have any questions or want to reach out to myself or Shannon, our email addresses are here for you. You're welcome to reach out to us at any time. And then last but not least, thank you to our May RDLA webinar sponsors. And again, thank you to our panelists and to all of you for hanging in there with us today. I appreciate all of you. So everyone have a great day, and we will see you in June.